Hello, everyone. Welcome to this 47th edition of the EBMT annual meeting. Welcome in particular to our Patient, Family and Donors Day. I think that at EBMT, we're always being very aware that different professionals and different stakeholders have different approaches to disease, and that we enrich the overall management by taking everyone into account and by bringing everyone into the core of the society. As a matter of fact, this 47th edition is also the 37th edition of the annual meeting of the nurses group. And along with that, today is the 15th Patient Family Donor Day. I still remember the early days where the Patient Family Donor Day was held somewhere completely separated from the venue of the Congress in a different setup, and it was somewhat removed from the actual core of the meeting of the society. That has already changed, and we do believe that patients, families, and donors need to be involved and be part of what we do. As a matter of fact, in 2018, actually in Lisbon, was when we finally created the patient advocacy group that is at the backbone of this day and at the backbone of the work that the society does with patients and families and donors. I think that it also has had an impact on the actual content of our overall meeting. We have a wonderful program today, and I'll let Natacha Bolaños give you a more detailed introduction to that. But we'll finish the program today with a special session on a debate on patient engagement in transplantation and cellular therapy. That I think is going to be extremely interesting, and these sessions go all the way till the end of the meeting on Wednesday, where one of our plenaries, plenary 3, will specifically deal with patient-reported outcomes, which are an essential part of how the field of assessment of new drugs and new therapies is moving the opinion and the outcome as measured by the patient. So without any further ado, I'd like to again welcome you all to the Congress, welcome you all to this Patient Family Donor Day. I'd like to thank Natacha Bolaños and all the team and the patient advocacy team and everyone else involved in providing this program and in having the opportunity that, despite the difficulties and the virtual circumstances, giving us all this chance to be together and to share experiences in this Congress, in this Patient Family and Donor Day. Thank you very much. Natacha, the floor is yours.
Thank you, Rafael. It is my great pleasure to be with you today on behalf of my friend, Brett Verhoeven, Chair of the Patient Advocacy Committee, and all my colleagues that have put so much passion and energy to build a unique and memorable day in terms of the range and hopefully quality of the sessions, but also in terms of the circumstances in which this Patient Family and Donors Day is taking place. Sadly, we cannot meet face-to-face. We are also missing many colleagues, healthcare professionals, many patients, advocates, and donors that cannot be today with us. The pandemic has forced us into an uncertain world, but one thing remains true. There is a simple power in people coming together. And today, we are connecting with people from every corner of the world. Today is about coming together as equals, sharing experiences and learning from each other. We will be speaking about post-transplant care, graft versus host disease. We will discuss the challenges for sexuality and fertility. We will dedicate a few hours to speak about new developments and donor focus. And we will extend our dialogue on CAR-T therapy and how hematopoietic stem cell transplantation impacts autoimmune disease. We will cover pediatric transplantation and the role of registries. We couldn't miss to include a special panel discussion on doctors, nurses, and patients' experience dealing with the COVID pandemic. And we will close the day with an interactive debate on patient engagement in transplantation and cell therapy. You are all welcome to use the questions and answers tool in the platform to ask questions, comments, and communicate your concerns. Let us know, please, your expectations, and we will do our best to provide you with the support you need. Finally, I would like to thank all the fellows within EBMT for their enormous work behind the scenes to ensure the delivery and success of this meeting. Thank you for staying this Sunday with us. I wish you a positive meeting, enjoy, and feel very welcome. I would like to give now the floor to Guy Bouguet to introduce the first session of the day.
Thank you very much, Natacha. Yes, my name is Guy. I will be chairing the session Introduction to Post-Transplant Care and GVHD with my colleague Sarah. I will give you just a short background of who I am. I'm a 15-year patient. I was transplanted 15 years ago, and I've been involved in all kind of advocacy regarding transplantation and lymphoma. Sarah, if you want to introduce yourself.
Absolutely. Hi, I'm Sarah Hutton. I am also a stem cell recipient. I had my stem cell transplant, in fact, 5 years ago on Thursday. So I'm celebrating my 5th anniversary of my blood birthday, having had leukemia. I'm also part of the patient advocacy committee for the EBMT, and very excited to bring you this day today, where we get to hear from so many of the leading edge practitioners and some patients who can also share with you their experiences and give you insights as well. Guy.
Sarah, I just want to highlight the fact that you have at any time the possibility to ask question using the tool. So please do not hesitate to ask your question. As you know, this session will finish by a 20-minute discussion where we will answer questions that were asked during the session. Now let's get into the subject. You know that getting a transplantation is not a quiet process. It starts by the first stress. The first stress is finding a donor, but finding a donor is just the first step of this long process. The real process of the transplantation comes when you receive the transplant, and then you have to deal with the post-care and potential GVHD issues. And we know that for some, GVHD could be a simple walk in the park, and for some, GVHD could impact their daily lives for months. So we wanted to make sure that today we were able to hear the experience from some of the best specialists on GVHD, but also counterbalance it with the testimony of a patient. So we will start by the presentation of Professor Fiona Diegman. Dr. Diegman is a consultant in hematology, oncology, and clinical lead for hematology at Manchester Royal Infirmary. Her main clinical interests are acute leukemia, chronic myeloid leukemia, and allogenic transplantation. She is the lead author of National Clinical Practice Guidelines on graft-versus-host disease, veno-occlusive disease, and respiratory viral infection following hematopoietic stem cell transplantation. She's also the secretary of the British Society of Blood and Marrow Transplantation and Cellular Therapy, chair of the Post-Transplant Pathway Expert Steering Committee for Anthony Nolan, and chair of the NHS England BMT Clinical Reference Group. Fiona, the floor is yours.
So much for inviting me to talk today. As you say, I work at Manchester Royal Infirmary, and I'm a consultant haematologist, and I look after patients who are early post-transplant, but I also look after patients at really any time after their transplant, be that a couple of years or right up to 10, even 15 years after the transplant. And it's a real pleasure to talk to you today about a project that I've been working on with the Anthony Nolan on a pathway for post-transplant care. Here are my disclosures. So I just wanted to give you an overview of my presentation first of all. I'm going to start by talking a little bit about the background to the pathway and why it was that we decided to move forward with the project in the first place. And then an approach to the pathway, and then talk to you a little bit about the roadmap itself, the main building blocks and what each of those mean. And then this pathway is all very well, but what are the next steps? So you want to talk about some of the next steps that we're working on at the moment. And then, as we heard during the introduction, the impact of COVID-19 has obviously been absolutely massive for patients, for families, and also for staff working in transplant units. So I am going to touch a little bit on the impact of COVID-19 as well. So firstly, why set up a pathway for post-transplant care in the first place? So I'd like to introduce you to this lady, Ruth Beeman. So Ruth is a patient representative and she's vice chair of the expert steering group. And I think this quote really sums up her experience and also probably the experience of a number of patients. So what she says, when I first left hospital, I felt so alone, more or less dropped from a great height and left to deal with it. This isn't how it should be. I feel passionately that the whole person needs to be cared for and not just their illness. So why is the transplant journey so difficult? Well, as many of you attending today will be very, very familiar with, the stem cell transplant can lead to a wide variety of physical and psychological complications. These can be multifactorial, including long-standing complications related to graft versus host disease, which we're going to hear more about later in the session. And the impact on mental health can be considerable throughout that entire journey, from before the transplant to even many years afterwards. And we know that there are guidelines that do exist on managing the later effects of transplant. And there are also JC standards, and all the centres that undertake transplants should be adhering to the JC accreditation standards. However, despite these efforts in writing guidelines and setting these standards, we know from studies that have been done that there's still quite a lot of variation in the provision of post-transplant care in different countries, including the UK and in the United States as well. So in order to get an up-to-date picture of what things were like in the UK, we did a survey of the provision of long-term transplant care in the UK. And this was actually a follow-up study because back in 2014, a colleague, Angela Hamlin, had done a similar survey. And this was, so our more recent survey was repeated in 2019. And there's some really striking features. So one of the key things that we noted was that a psychological assessment was actually only undertaken in about a third of patients. And what I mean by that is that it was included as part of a sort of standard operating procedure in about a third of patients. What had really improved with time was that almost all centres had a very set protocol for monitoring patients after the transplant. And one thing, again, which struck us from the results was that although centres all had multidisciplinary team meetings to discuss a patient's new diagnosis or also relapse of the disease, there was only a few centres that had MDT meetings to discuss patients with complex long-term problems following a transplant. The other thing that we looked at was access to specialist services. And as many of you will know, it's not uncommon to need the input from all sorts of different specialists after a transplant. And some of these can be medical specialists, like cardiologists or respiratory specialists. And then some of them are focusing on nutrition, like dietitians or physiotherapists, and there can be quite a breadth of specialist input that can be needed. And there were some reassuring findings from this survey, in the sense that all centres had access to a clinical nurse specialist, for example, which was really great to hear. But there were some services where there wasn't really much access, and that's represented by the lighter blue bars in this chart here. And so we can see that some centres didn't have access to fertility specialists or occupational therapists, and it was a little bit less clear for things like cardiology and gastroenterology as well. So why do these barriers exist? Why is it quite difficult to run a service for patients that are several years out of transplant? Well, not surprisingly, the biggest barrier does seem to be money. And the finance side of things seems to apply to a few things. That can apply to staffing, just literally having the funding for posts, particularly for psychology staff, but also applies to more simple things like just being able to organise tests. And then there's some other factors that come into play. One in particular is geography. Certainly in our centre in Manchester, we do have patients who have to travel sometimes a couple of hours to attend clinics, and that can be a particular challenge if it's difficult to reach the hospital due to traffic issues or issues with public transport. So, why did we go on and develop a pathway? Well, one thing that was sort of becoming obvious, that although there was some guidance out there and there were some JC accreditation standards, there weren't really minimum standards for the care that patients should receive after the transplant. We wanted to highlight the core services and support packages that should be available for patients. And by this, I mean things like, having psychological support, having that access to fertility services, for example, access to dietitians, those kind of things. We also acknowledged that it could be really difficult for centres to develop and fund services. And it was hoped that by putting the pathway together, that might help centres be able to raise the profile of post-transplant care within their institution and potentially get more funding to develop a service. And also, we thought it might be helpful for commissioners who have to make decisions about funding services to try and invest in key parts of that pathway, whether that's things like increased psychological input or some of the things that are carried out in primary care, like vaccinations, for example. So, how did we go about this? So the Anthony Noden, who, of course, I'm sure most of you know, do an amazing job at finding donors for patients undergoing transplantation, really helped to set up this expert steering group. And the expert steering group consisted of healthcare professionals, as well as local representatives from the National Health Service, so managerial staff, and importantly, patients and carers, and also some allied health professionals and GP. And there was also a review of the existing literature that was out there on the subject. And then quite an extensive consultation afterwards with patients and family members and healthcare professionals. So I won't obviously go through this full list, but this is a list of the people who are part of the expert steering group. And so you can see that it's quite a sort of range of diverse backgrounds, covering everything from psychology to and obviously a number of patients as well. And this was back when we could meet face-to-face, which is obviously a little bit more different now. So just wanted to talk you through the 5 main building blocks of the pathway. So there are some things that are important throughout recovery, things like having access to a clinical nurse specialist, for example. Some things which are more important at the beginning, preparing for transplant. And then there are some elements that are more important in the early post-transplant period. So this is things like monitoring for infections, for example. And then there's other elements that are more important further on after the transplant. And that's looking at ongoing prevention of other complications, for example, monitoring for second cancers, for example. And then there's other things that might be needed in terms of additional treatment and support. So that could be palliative care support, for example, or ongoing mental health support. So this is a really, really busy slide, and I do not intend to go through this in detail. But I think what it does do is give an overview of the different building blocks of the pathway. And it shows the things that are important throughout recovery. So that's access to information, access to a key worker, like the clinical nurse specialist, for example. And then shows the different stages of the pathway from those early post-transplant care to the later monitoring as well. And what it also tries to describe is how that care could be delivered. So that some of that will be tertiary care delivered by the transplant centre, But it's also really important to have those links with secondary care as well, because that's where some of the other specialists might come in as well. And importantly, things like breast cancer screening is probably going to sit with secondary care. And obviously primary care are so important in terms of delivering some aspects of this pathway as well. So one particular example is certainly in the UK, vaccinations after the transplant, and this is so important at the moment with COVID-19, are being delivered by primary care. So having put this together, we were obviously keen to make sure that there was support for the pathway from those outside of the expert steering group and the wider community. So we undertook a survey of patients and families, and also of healthcare professionals. And remarkably, almost everybody thought that the key things had been covered. And then this was strengthened also with some focus groups and telephone interviews as well. So this is all very well, but what about next steps? What are we trying to do having put this all together? So one thing that we've been particularly working on recently, because it's hugely topical, and we've linked together with the British Society for Blood and Marrow Transplant Cellular Therapy as well, to write vaccination guidelines. And we can also hoping to use these to create a vaccination passport for patients that can move between the transplant centre and primary care. We're also writing some practical guidelines and other things like neurocognition, for example, holding education days for nurses and allied health professionals. And there's also been increased research into psychological support and into financial and resource barriers. And also it's hoped to establish some activity books for children in terms of an educational resource. The Anthony Nolan have been amazing at leading and organising these next steps. So just to quickly touch on before we finish, the impact of COVID-19. I mean, COVID-19 has been absolutely devastating, as we said earlier, for patients and families and for staff. There have probably been a couple of positives. We certainly in our centre we've implemented some virtual consultations, which I think have been appreciated, and particularly for patients that have to travel a long way to the centre. I think it's absolutely raised the profile of vaccinations, and I think it's meant that our consensus guidelines will probably move forward a little bit quicker. It's really highlighted the psychological impact because I think the emotional well-being has been much more challenging during this period of time. And just a couple of things that I think has been really helpful in the UK is that there have been guidelines led by the British Society for Blood and Marrow Transplant. And there's also been a lot of shared learning because there's been a weekly national meeting to talk through the particular problems that centres are facing. And I'm quite sure that that has been really helpful for patient care as well. So just to conclude then, we've talked a little bit about the background to the pathway, how we went about it, and some of the key building blocks in the post-transplant pathway. And then I've tried to highlight some next steps and also touched on the impact of COVID-19. So thank you so much for listening, and I'll be happy to answer some questions in the Q&A session.
Thank you so much, Fiona. Really a wonderful piece of work. We're very excited as patients to see that this idea of the whole patient being treated and considered it's very refreshing and so much needed. I'm now going to hand back to Guy to introduce our next speaker. I believe we will be now speaking with John Murray. Guy, can you please confirm?
I think I don't think John. Yeah, John is connected. Sorry, sorry about this. So yeah, it is. Thank you, Sarah. So it's my pleasure to introduce John Murray. John Murray is a hematologist, transplant nurse, and a clinician for bone and marrow transplant at the Christie NHS in United Kingdom. He's been the president of the nurse group of the EBMT for the last 4 years. And John is extremely involved with everything related to GVHD and how to handle and support patients with GVHD. John, the floor is yours.
Much. Hello, good morning to everybody. Thank you, Guy. Thank you, Natacha, and the rest of the committee for inviting me here today to talk. A special hello, I suppose, to everybody who's in the UK. For today is Mother's Day, so happy Mother's Day to all of those people who've got up early and instead of enjoying breakfast in bed are listening to us all talk here at this year's annual conference. So thank you for joining. So what I'm going to talk today is about the daily impact of graft versus host disease. Now, I often find things like this a little difficult for a couple of reasons, I suppose, and the biggest elephant in the room is that we're predominantly, all of us today that are speaking to you are nurses, doctors, physiotherapists, and we're telling you how the impact of graft versus host disease affects you, which seems to be the wrong way around, which I'm very glad that we have patient speakers at the end of this, as is correct, to give your perspective on what it is. We can tell you the things that we observe and the things that when we ask questions, we get replies to. But that's sometimes lost in translation. And I don't think that we know everything about graft versus host disease and how it affects people. So we can give you our view on it. And this is, of course, a personal view of what I see on a day-to-day in my practice and how it affects the patients that I look after. The interactions that we have. So, how do we go down a slide? There we go. So we're going to talk about graft versus host disease. And unfortunately, year by year, graft versus host disease continues to be a problem for our patients. And unfortunately, it continues to be a leading cause of non-relapse mortality in our patient group. And depending on which pieces of publications that you read, graft versus host disease can affect anywhere between 10 and 80% in the acute variety and 30 and 80% in those with chronic graft versus host disease. And this is all dependent upon a lot of factors. So ages of both the patient and the donor, where you're getting the cells from, whether that is bone marrow, whether that is stem cells, whether that's a cord transplant, whether or not it's a haplo. So all of these things have an impact as you move forward through time with your transplant in the post-transplant setting, and the degree and the intensity of the graft versus host disease that occurs is very much dependent upon those things that are happening at that point of transplant. Unfortunately, once graft versus host disease does develop, we have to change treatments and see if we can get on top of these things as quickly as possible. And steroids remain really the gold standard and the first treatment that people will have. But this is not a perfect treatment, and people do fail these and require second and often third or even fourth line treatments to get on top of their graft versus host disease. And graft versus host disease itself is pretty difficult to treat if it is at the higher end of the spectrum and can become resistant to the steroids, requiring these second and third and fourth line treatments. And this is where all of our problems really begin. So, as I said, I'm very much on the outside looking at this and how we're dealing with this with our patient group. So what we've done as nurses and doctors and other specialists is look at consensus documents. So getting a group of people in a room and having a brainstorm about what you can do, how you can look after patients from all the different aspects. And there are a large variety of publications. And Fiona alluded to a couple of these, I think, on her second or third slide in her presentation. There's publications by Bouguet and a couple of other authors that she had on the bottom of one of her slides. The other large documents that were produced outside of the UK, this is a USA and across the board consensus document, was several years ago now and is probably in the realms of being updated. But it was 5 or 6 papers that were pulled together looking at all of the different aspects of graft versus host disease. The one that I think is the more important directly from the patient's perspective is the ancillary therapy and supportive care in chronic graft versus host disease. I think this is a really important document, and is one that it's not too difficult for anybody to read, really. I think it gives some really good hints and tips about how to look after your graft versus host disease once it's developed, the things to look for, and how you can treat the graft versus host disease once it has developed. And even there are some preventative tips in there to stop them from getting worse. So I think it's a really useful document, and I think I've listed it at the end for you to have a look at as a reference document. So there's a long list of prevention and then treatment options in this. And as I say, it covers pretty much everything. So it's looking, I mean, I suppose if you work your way down, so eyes, mouth, skin, sexual dysfunction, psychological care, rehabilitation. So it's really very broad in its outlook, trying to cover all of the aspects that chronic graft versus host disease can possibly affect people. So outside of that document, what I wanted to do really was put this into a context, and you know, Fiona spoke about, she has a patient herself that's on one of the groups, and I think it's good to have interaction with people. I think that I'd like to introduce you to Martin here. Now Martin's a chap, crikey. He's just an incredible fella. I've known Martin now for more than 10 years. We met back in September 2011. I tend to meet people for the first time the week that you're discharged from your transplant. Sometimes I meet people before I do bone marrow examinations, so unfortunately the uncomfortable and not very pleasant test of having a bone marrow aspirate and a trophine performed. I run a clinic doing those. So I sometimes meet transplant patients before that, but most of the time I first meet people that first week you're discharged from your transplant. And I remain with you then for the rest of the transplant time that you're with us. So I run the late effects clinic as well. So we've got people who are now 35 years post their transplants that we still see once per year for just a check-in, really, making sure that everything is still being looked after. So Martin's been with us now, and he's in our late effects clinic, and we see him now on an annual basis. But his time was a particularly rocky one, and I spoke to him just obviously before doing this talk, asking him if it was all right if we spoke about him, and hopefully Martin's online watching, so morning to you, Martin. He was originally diagnosed just over 10 years ago. And he's a very, really keen golfer at the time. And this is obviously having an impact on him being able to get out, being stuck in, having his transplant, and not being able to get out and about. Unfortunately, 9 months after his transplant, he started to develop some signs of chronic graft versus host disease. We treated him initially with steroids, and things seemed to be settling. And he was thinking about getting back to work. We got him off the steroids. His GVHD was under control. And then out of the blue, he started to get really quite severe back pain. And he went off to see an osteopath, and they thought maybe this is one of those unfortunate side effects from steroids, that he was getting steroid-related pain. But he was noted that he had some disc bulges in his back. And this all settled a little bit, but didn't completely go away. And then we get to about 16 months post his transplant. He came into clinic, and his wrists, his shoulders and his hips, they were all getting really, really tight, and he was suffering with a lot of cramps. And these were really starting to restrict his movement. And then over the next few weeks, we noted his skin was becoming tighter, and he was developing sclerodermatous skin changes quite rapidly, to the point where he was reduced to using a wheelchair, was unable to walk into clinic. So back onto the high dose steroids, which seemed to calm the graft versus host disease down quite quickly. And within a couple of weeks, he was back out and able to walk again. He was actually getting up to walking a mile within 2 or 3 weeks of starting the steroids. But the sclerodermatous changes, unfortunately, continued to progress and were causing tightening, thickening and tethering, particularly around his shoulder joints, around his elbows, wrists, and hips. And he was really unable to bend forward. He couldn't touch his toes anymore. I must say I struggled to touch my toes at the best of time, but he couldn't bend over far enough to do that. So we started, as well as the ECP steroids, we started him on ECP as an alternative treatment to see if that would get on top of things. And he was on ECP for a couple of years worth of treatment. Within all of this, Martin is trying to be as active as he possibly can. So having input from occupational therapy and physiotherapy would be ideal. Now, within the trust that I work, unfortunately, at the time, we didn't have any outpatient services at all for OT or physiotherapy. And this is coming back to one of the points that Fiona made, money. There was no money available to employ anybody. The only way you could get this is if you were an inpatient actively on the ward. And it was a short course of treatment. And then once you were discharged into the community services, where they're not as up to speed with treatments and options for people with chronic graft versus host disease. So this is incredibly difficult for people who have a specialist problem. How do people look after this? So Martin was very proactive. He got in touch with a private physiotherapist, and attended sessions and has worked a relationship with this person over several years now. Functionally, he was getting worse as things were closing in from his skin point of view. Muscles were becoming quite affected by this, and they were shrinking down as a consequence of the long-term steroids. And he was also getting lots and lots of infections and was in and out of hospital multiple times, requiring things like intravenous immunoglobulins, which we give to patients who have repeated infections, particularly over the winter, to try and foreshorten the infections that they're getting. Unfortunately, Martin had several other problems because of his ECP. He had a central line in. This got blocked, infected, removed, put back in. He then suffered with a massive clot in his leg. He then went on to have cataracts that developed over the next year. So lots and lots of problems that are very well documented. You just don't expect every or one patient to get every one of those particular problems. So Martin carries on with his physiotherapy, his ECP, his steroids, second line treatments, and slowly things are getting better. And a lot of this is down to the absolute hard work and effort that Martin was putting in with his physio and OT. He joined a variety of Macmillan exercise classes at his local hospice to try and improve things as much as possible. Once his lines were out, he was able to start swimming, and he was becoming quite active doing those things. So Martin, as I said, was a very keen golfer. He was part of a large group that used to go away abroad on holiday. Martin was unable to do this for quite a long time. He eventually managed to get to one of their trips in 2018 when they went to Swansea, and it was his first trip back, his first couple of games of golf, and he actually came away with a trophy, he tells me, which was much to the annoyance of some of the people that were playing golf more regularly than he was. But it was 4 rounds of golf over 3 days. He couldn't walk around the whole of the golf course. He had to use a buggy to get around, but was really quite pleased to be able to compete there. He then went to Portugal in 2019 and has carried on with the group. So this is the group he was at in 2019, and here's Martin here at the back. So it's really pleasing that he's managed to, within the confines of his still ongoing graft versus host disease, which has pretty much burnt itself out. Now he's got fixed movement and limited range in pretty much all planes of motion of his shoulders, arms, wrists, and hips. But he's still able to get himself out there and be quite active in his group still. So we've been asked to also mention briefly about some COVID-19, because this is very pertinent at the moment. Some of the advice, I'm sure, within some of the countries will be slightly different. Within our practice at the moment, we are giving the vaccination to people who are more than 3 months post their transplant, as long as you're on less than 0.5 milligram per kilo of systemic steroids. And it's pretty much across the board we're able to give that vaccine. And so far we've not had any particular problems with patients with chronic graft versus host disease or in the immediate post-transplant setting. So we started a little bit early, I think. So I think that maybe we've probably finished just very slightly earlier than planned. But I'd like to thank you for this opportunity to talk. We, as Fiona says, have a Q&A at the end. So I'm looking forward to some questions and hopefully being able to answer them. I hope that the rest of the morning is really good. Thank you very much.
Thank you so much, John. It's really been interesting to listen to the work that you've been doing and to listen to one of your patients' experiences. And I would very much like to ask people to please put questions in the tool to make sure that when we come to the Q&A session, that we've got lots of questions for our fantastic speakers today who've given up their Sunday mornings, and as John was saying, in the UK, their Mother's Day mornings. So I'm hoping that they aren't in any trouble with their mothers. What I'd like to do next is to introduce you to, in fact, our patient speaker for today on post-transplant complications and particularly his experience with chronic GVHD. I'd like to introduce you to Sam Williams. Sam is a very inspirational speaker about the experiences that he's had in his long journey, and his journey in particular with GVHD post his transplant. So, Sam, thank you so much for being with us this morning, and I'm going to hand over to you.
Very much, Sarah, and good morning to everybody. It is an absolute pleasure and an honour to be joining you this morning at the EBMT 47th Annual Congress. I've long been an admirer of the EBMT, and it is an absolute pleasure to be here today and to be speaking with such esteemed colleagues and to our wonderful community. And I really look forward to answering your questions at the end of this session, so please do feel free to ask anything. First of all, I'd like to introduce myself. My name is Sam Williams, and I am, of course, a transplant recipient. I received my transplant back in October 2017, and I also work for an organisation called the Aplastic Anemia Trust in the UK, which provides support and ongoing support for people with this extremely rare blood disorder. In terms of the overview of what I'd like to cover today in this short speech that I'm giving, there are a number of aspects that I'd like to speak about. Firstly, I'll give you an overview of my general background, my medical history, and the journey through my transplant and beyond. Specifically, I will be talking about chronic GVHD and the ways that it affects my daily life and the conditions that it places upon me. I will also speak further about some of the treatment that is available for GVHD, which of course Fiona and John have spoken about, but I will also speak about the ways in which those different treatments have affected me as well, and how successful they've been. So firstly, this is just some information about my medical history, and it is quite a long and complex journey. At the age of 3 years old, back in 1999, I was diagnosed with a very rare blood disorder called aplastic anemia. This condition means that the bone marrow is not producing enough blood cells, including red blood cells, platelets, and white blood cells. As you can appreciate, this was a very serious condition, which made me more prone to things like bruising and bleeding, contracting infections, and of course experiencing lots of fatigue, which for a 3-year-old boy wasn't really an ideal situation. This was of course a very difficult situation, and this was of course a very difficult situation, and at the time I was treated with a form of treatment called ALG. This obviously wasn't a transplant, and it wasn't a curative treatment, but it did mean that I was able to live a normal life for approximately 17 years. There was, thankfully, over those 17 years, allowing me to live a very normal life, and I was able to attend school as normal, which was great. Unfortunately, later on, at the age of 21, while I was at university, I contracted sepsis, which is of course very life-threatening. This was thankfully treated successfully, but it did indicate that there were some ongoing and serious problems with my bone marrow. At this point, I had a bone marrow biopsy, which revealed that I wasn't suffering from aplastic anemia anymore, but a condition called MDS, or myelodysplastic syndrome. It was at this point that I was told that the only option for me to survive and the treatment for me to receive was a stem cell transplant. As I don't have any siblings, brothers or sisters, having a matched sibling donor wasn't an option, and it was at this point that a search began for an unrelated donor. I'm very lucky that in just 6 weeks after the search began, a matching donor, a 10 out of 10 match in the form of an anonymous 45-year-old German man, was found for me, and in October 2017 I received my stem cell transplant. Initially, things went really well with that. Of course, as we've seen before, there are a lot of complications that can occur post-transplant, including recurrent infections, and I did experience acute skin and gut GVHD at that time, which was quite unpleasant. This was, of course, a very difficult time, but generally things continued to improve. However, unfortunately, around 18 months post-transplant, I experienced chronic skin GVHD, where things were starting to get worse. I'd experienced skin GVHD for many, many months after my transplant, but around 18 months post, the skin condition started to get worse. As you can see in that photograph there on the right, that was of my leg at the point that I was diagnosed with chronic skin GVHD. As we've seen before, the skin can become very tight and tough. It was very red, very sore, and very painful. All of these things combined together do have an impact on my daily life. For example, I experience chronic and very severe pain, and at times I have to take painkillers such as morphine in order to control that. Things like that as well with the restricted movement in my joints, as John mentioned previously. The tightness of the skin does quite severely restrict my range of movement in my joints, which has an impact on my ability to do everyday things such as
the very best in the field,
and it can be
now at the 47th annual meeting and a second virtual
restriction in movement and whatnot, and of course the pain that I experience, and this really does have an impact on my everyday life. As you can appreciate, experiencing severe pain and things like that does have a detrimental impact on mental health, and this is something that I've experienced. In the time that I've had chronic skin GVHD, I've been treated for both anxiety and depression in this time, which has of course been quite a challenge. Some of the treatments that we use to treat GVHD involve the use of immunosuppressant medications, which weaken the immune system. And again, this can make people quite prone to developing infections. Unfortunately, this is something that I've also experienced. I'd also like to talk about some of the treatments that I've received for GVHD. Initially, as John and I think Fiona have mentioned, the first line of treatment in the UK is to use things like steroids and cyclosporin, which is an immunosuppressant. Unfortunately for me, when the chronic GVHD developed, this didn't really work very well. The skin GVHD wasn't improving, I was experiencing a lot of pain, and things just weren't really going very well. Thankfully, a few months after I was first diagnosed, I was commencing ECP, as John has mentioned, which is also known as extracorporeal photopheresis. And this is a treatment which works by sort of filtering the blood, removing the cells that cause GVHD, and treating them with ultraviolet light. This is unfortunately a treatment that is quite a slow progressing treatment, and I have been told that it will take 2 to 3 years for this treatment to work and to see a decent effect for me. Thankfully, so far, this treatment is working quite well. I've been having it for about 18 months now, and things are going really well. I'm in much less pain than I was, and the range of movement has increased quite significantly in my joints, which is wonderful. However, there are some kind of side effects and issues surrounding this treatment, as John mentioned. I'm one of those people that has a central line in as well, and I've had issues with that becoming blocked. I've experienced recurrent infections with that as well, which is always a problem. ECP as well can have some kind of minor side effects, including fatigue after the treatment. So quite often when I've had my treatment every month, I can feel quite tired for a few days, which has an impact on my ability to do things. Also, as I've mentioned previously, the time span for ECP is quite lengthy for people with chronic GVHD. I've been told that it could take 2 to 3 years for this treatment to be effective and to work for me. This also entails having to attend regular appointments. At the moment, I have my treatment on 2 consecutive days once a month. However, initially it was every 2 weeks. And of course, this has meant that I've had to adjust my daily routine and plan things around my treatment, which of course, for some people is really quite inconvenient. But nonetheless, things are generally going extremely well for me. I'm feeling really positive about my progress, and overall, I'm very happy. And finally, I'd like to thank you for listening to my presentation today. I am aware that I've had some issues with the connection, and I hope that you've been able to hear me. But thank you very much for your time today. Thank you.
Thank you so much, Sam. Really, really interesting to hear your experience and hear it from the sort of first person point of view. Very, very valuable. Thank you very much, and very much good luck to you on your ongoing journey. Right, I'd like to turn now to some questions for the participants. At least, sorry, from the participants for the speakers. I'd like to start off with a question for Fiona. Fiona, there's a question here for you that is about aftercare. What advice can you give to patients who are not living in the UK and where there are no guidelines or an outline of a pathway, and perhaps where aftercare is not taken care of?
Yes, I'm certainly happy to answer that, and it's a really good question. So actually, I think there's lots and lots of things that patients are able to do. A lot of the advice that we give to patients in our longer term effects clinic is actually just general healthy lifestyle advice. So some of that is about preventing cardiovascular complications, So having a good diet, maintaining a healthy weight, making sure that you have checks of glucose and cholesterol and blood pressure, and all of these can be done by a general practitioner doctor in primary care. The other piece of advice that I think is really important is about keeping up with cancer screening as well, because unfortunately patients after a transplant are at slightly more risk of second cancers. So that's things like taking care in the sun, so wearing a hat, wearing high factor suntan lotion, making sure keeping up with dental checks, and also any national cancer screening programs, whether that's cervical cancer screening or breast cancer screening and things as well. And then I think there's probably some very particular things related to the COVID-19 situation as well. And firstly, about just sort of trying to maintain good mental health as well as possible, and that's just trying to connect with people, albeit often that's happening virtually at the moment. And also simple things like taking vitamin D supplements, and also when it is offered, is to take up that offer of the COVID vaccine, as well as the flu vaccine if that's offered as well. Thank you.
Very much, Fiona. I have a question now for John. Actually, John, I'd like to say that the story that you told about Martin was very familiar to me. I felt like you were telling my own story. But anyway, the question we have is this one: how do patients have to behave with unusual physical events? After transplant, should they always keep GVHD in mind, even a very long time after their transplant?
Sadly, yes, but not always, I suppose. The graft versus host disease itself, as a chronic manifestation, is unusual to appear completely new more than 7 years after your transplant. So there are people who can be 3, 4, 5 years from transplant, have never had any acute graft versus host disease, that can just develop some signs of chronic graft versus host disease that might need treatment. So once, I suppose in theory, you get to 7 or more years out of your transplant and you've never had any acute or any chronic whatsoever, it would be highly unlikely that you would then develop something. It is still possible, I suppose, but it would be more unlikely. For those people that have had some acute graft versus host disease or chronic GVHD that has come and gone over a period of time, then I think it's always mindful to be thinking, whatever a new problem is this related to my graft versus host disease? And I don't think any of us, Fiona, myself, any of the clinicians or nurses that you work with would ever not pick the phone up and go, oh, okay, describe your symptoms to me, and try and put your mind at ease to whether this is a manifestation of your GVHD. So what I would say to people is, if you've developed something, call your clinical nurse specialist, call your point of contact at the hospital, and just have a chat with them, have a discussion with them. None of us would ignore you or push you away, or, you know, I think it's really important for that ease and peace of mind, because as Fiona said, all of the screening and doing the things like checking your glucose, your lipids, all those things are very easy through your primary care provider, through your GP, but they might not be quite up to speed with the more unusual and later effects of chronic graft versus host disease and how that affects people. So it would probably be unfair to try and ask your GP, or do you think this is? Because what they might do is say, well, I don't know. Why don't you? So you're kind of making it a two-step process there by going to your GP first, who might not be able to answer to you, and then you lose confidence in your GP because you think they don't know what they're doing, which is not the case. The GP is specialist in everything, but not quite a specialist in certain areas as the primary hospital that's looking after you. So I would probably say come to your primary point of contact first, and just have a conversation on the phone with them. You don't need to go into the hospital. A lot of it can be done over the phone and just having a chat with somebody for a couple of minutes and put your mind at ease. I'm sorry that you had as many problems as my Mangi.
Thanks so much, John. Really appreciate it. Just now turning to a question that's come up for you, Sam, and I'm going to read it to you, knowing that I'm not a clinician, but this clearly comes from someone who is. It says, looking back at your journey, at which stage do you feel that we as clinicians could have done better to facilitate management of your GVHD? So, and then the sort of second part is, what can we do as clinicians and researchers to better support GVHD patients?
Thank you, Sarah. That's a very interesting question, actually. And, you know, I am very lucky to say that I believe that I have had really quite exceptional treatment at every stage of my journey. But I would say that probably one of the issues that comes up time and time again, and it is actually raised in the post-transplant care pathway that Fiona discussed earlier today, is the aspect of psychological well-being. I would say that this is an aspect of post-transplant and GVHD care that is somewhat neglected to an extent. Sometimes it can be quite challenging to access psychological support. You know, I'm sure the clinicians can relate to this, you know, with long waiting times and referral processes to psychological support services. It can take quite a long time to get access to those kinds of support for patients, which is something that I experienced. For me, in the end, I relied on a charity to provide psychological support for me, as the waiting times were quite extensive and there was an urgent need for support. So yes, I would say that that is probably the main aspect that I would focus on, definitely.
Thank you very much, Sam. And it is a nice transition to the next question, and that question is for Fiona. GVHD is a step that most of the patients have to go through. The question is, how could we better prepare physically and emotionally? And then a related question to that was exactly on what Sam just talked about, which is the psychological support. In some cases, psychological support is part of the multidisciplinary care at the hospital, but in many cases it's not. And there is a cost issue, and the cost issue is not on the system here. The cost issue is on the patient itself, and how can this be covered for the patient, because you know emotional support is most of the time out of pocket expenses for the patient. So 2 questions for you, Fiona.
Thank you very much. So if I start with the first question, is of how people can be better prepared for graft versus host disease if it does come. I guess the first part is probably education, actually, because sometimes GVHD can be easier to treat if it's picked up earlier. And so I guess the journey with the education has to really start before the transplant. But I know certainly some of the patients that I've looked after have said that there's so much information given before the transplant that it can be completely overwhelming, quite difficult to take all of that in. So even though GVHD is mentioned at that point, it might not be the perfect time to sort of really digest some of that information. But certainly it's helpful to continue that process of education after the transplant, continue to explain what kind of things to look out for, because then it's potentially possible to start that treatment a little bit earlier. And also just prepare people who have gone through a transplant about what the next challenges might be in that transplant journey with the graft versus host disease. There is quite a lot of literature available. There's some patient information booklets. The Anti-Nolan have certainly done a booklet about sort of what to expect after the transplant, and in particular the graft versus host disease side of things. And then moving on to the mental health support. And again, I would say I think this really does need to start before the transplant. I think in an absolute ideal world, and it is really challenging to do this because of the resource issues which we've already described, is it would be helpful to have an assessment of a patient's mental health ahead of the transplant, so that support can be put in place at that point, and also to particularly identify patients where they might have had particular issues in their life before coming to the transplant that might make them more prone to struggling from a mental health point of view afterwards. And then after the transplant, also having those regular check-ins, probably by the key worker, by the clinical nurse specialist, about how people are feeling after the transplant, and asking those questions, so that if additional support is needed, whether that's from a psychologist or a psychotherapist, or whether that's adding in medication to support, then that can be started at an earlier stage as well. Thank you.
Thanks so much, Fiona. It certainly takes me back to pre-transplant days, and the clinician who was looking after me at the time, drawing up a roadmap of what the future might look like. And if I hadn't taken a photograph of that, I would not have remembered that over the subsequent years, for sure. So thank you. Yes, there's always a lot to be digested as a patient before transplant and continuing after. I have a last question as we're coming to the end of our time, and it's for you, Sam. Really just wanted to check in with you about COVID and your experience of this past year.
That's wonderful. Again, this is a very interesting question. And to an extent, I actually think that sometimes we transplant patients are almost pre-prepared to deal with the challenges of a lockdown. As it stands throughout our treatment, and having a transplant and whatnot, we are frequently kept in very strict isolation. I can certainly relate to my own transplant being in an isolation side room for probably 3 to 4 weeks, and not being able to see the outside world. So to an extent, when we went into lockdown last year, I was already prepared with how to cope with isolation and how to keep myself occupied. I would say, however, there have been some challenges with it, because just before we went into lockdown in maybe March last year, that was a point where I really felt that there was a turning point in my health and GVHD. I was starting to be more active and get out and about more and start to enjoy my life again. And then all of a sudden that was naturally curtailed by the imposition of lockdown measures. So although it is a very difficult balance, although I would say I am prepared to cope with lockdown, it was a very frustrating thing to see that my recovery was kind of hindered to an extent.
So relate to that. Thank you very much. Guy, did you want to address another question?
Yes, absolutely. I just wanted to say, first of all, that Sam is perfectly right. I think as transplant patient, being in lockdown was something that we were already prepared for. And the experience around me showed that we probably didn't suffer as much as the rest of the population. But the last question was something that Sam mentioned in his presentation. It's about fatigue and how patient can above GVHD and all that, those physical trouble, fatigue is something that patients do suffer a lot. And the question is for John: is there anything, because fatigue was not mentioned anywhere else other than Sam's presentation, anything that is in place to care for fatigue or offer patients some type of support?
Thanks, Guy. There are some places, certainly in the UK, where you can go to chronic fatigue clinics. I know there's one in Greater Manchester. Chronic fatigue is certainly a massive problem for all patients post-transplant, irrespective of whether they've got graft versus host disease or not. It's a big problem for returning to work, returning to caring within your own family, back to full-time education. So lots of our patients suffer with fatigue. There are some, obvious and easy things that you can do, making sure that you have a clean area before you try and go to sleep. So turning off screens an hour before, not drinking coffee or other stimulants before going to bed, doing the things like a milky drink, sometimes playing some more relaxing music as you're going to bed, having blackout blinds in your bedroom so it's completely dark, wearing an eye patch, sometimes putting in earbuds to reduce the noise. So it's doing all of those things to try and allow you to get a good night's sleep, which then sets you up for the following day, so that when fatigue strikes, at least you've had a good night's sleep. Then doing exercise. Exercise is possibly the best thing that you can possibly do. So having short bursts of exercise every single day, trying to do something that doesn't completely fatigue you, but stresses your body so that you are able then to go to sleep. So if you're not doing anything at all during the day, then you're not going to be tired at night. There's some conversations about not having naps in the day, so that you do make yourself properly tired at night. Otherwise, you end up having multiple naps throughout the day, then not sleeping at night, feeling more fatigued the next day. Fiona mentioned having a good diet, I suppose avoiding alcohol, having a good fluid intake. So there are lots of basic things that you can do to try and improve your situation as much as possible. But even doing all of that, some people remain extremely fatigued afterwards. It's a really difficult thing to get on top of.
Thanks so much, John. Really appreciate that. What I'd like to do now, because we're at time, although we have a lot more questions we would like to ask, is to thank you all, our presenters, and my co-chair, Guy. Thank you so much for your time this morning and for sharing your knowledge and insights. It's been very, very helpful. Fiona, thank you in particular for the work that you're doing around the whole person and treating that whole person. John and Fiona, again, just lovely to hear that there are some things as a patient that you can take control of and use to live a better life, diet and exercise as much as possible. And making sure that you are following up with general healthcare with your local physician. And Sam, thank you as well for your bravery in sharing your story. Really, really appreciated your openness on both the sort of physical and mental overall well-being impact that the transplants had for you, both positive and not so positive. So thank you very much, all of you, and we'll finish our session here now. Thank you.